In this module, you will learn about some challenges you might face on your breastfeeding journey. We will look at some of the common concerns parents frequently have and what you can do about them. We will also let you know where to turn for help and hopefully add some new tools and skills to your breastfeeding toolkit. Breastfeeding is a journey, and it may take you and your baby some time to learn and master it. Along the way, there may be some challenges. For the purpose of this module, we will divide these into common challenges for baby and challenges that mums face. As a breastfeeding mum, you may experience sore nipples, concerns about your milk supply, inverted nipples, plugged ducts, engorgement, mastitis. For baby, some of the common challenges are a sleepy baby, fussy baby, a baby with jaundice, baby that will not latch, slow weight gain, tongue tie, and spit ups. Newborns tend to sleep between 12 and 20 hours a day in the early weeks and typically wake often to feed. However, some babies don't readily wake to feed 8 or more times a day and may need to be woken until they wake on their own for these important frequent feedings. Helpful tips to use with a sleepy baby are: keep your baby skin to skin as much as possible. Skin to skin stimulates baby's reflexes for feeding, such as rooting, crawling movements, and pushing up to find the breast, and they're more likely to start searching for the breast. Skin to skin also allows baby to decide when and how often to breastfeed. Being skin to skin helps baby's breastfeeding behaviors by the smell of the milk, and they can find the breast easily and plenty of opportunities to practice. If you are not skin to skin, it is important to watch for early hunger cues so that baby gets as many chances to breastfeed as possible. Licking lips, clenched fists, flexed arms, turning head side to side, rooting for the breast are all early cues that show you that baby is ready to breastfeed. Change baby's position. Rub baby's back, talk, and sing to the baby to help wake baby up. If your baby's diaper is wet or dirty, changing the diaper can often wake them up. Leave them dressed in only a diaper to keep them awake and for skin to skin. Hand express a few drops of milk when baby is near the breast. Feed this to your baby on a clean spoon. Smelling and tasting this milk can help wake baby to start to breastfeed. If baby is able to latch but is sleepy or only feeds for short periods, try doing breast compressions during the feeding. By increasing the pressure in your breast tissue with breast compression, each of baby's sucks will deliver more milk, increasing the amount of milk baby gets with each suck. To do a breast compression, place the palm of your hand on your breast tissue and compress the breast with your fingers. If you've tried all these tips and still have a hard time feeding your sleepy baby, consider talking with your doctor or midwife, calling 811 or your local public health or breastfeeding professional for more support. In the early days, if a baby is fussy and showing hunger cues, it is likely a readiness to feed sign. There are so many reasons why your baby may be fussy, however. It could be that your little one needs to be burped, has a wet or dirty diaper, needs extra comforting, is going through a growth spurt, feels unwell, is entering the period of purple crying, and even more. Sometimes it takes a little bit of trial and error to see what the needs are. As you get to know your baby more over time, you will get a better sense of what might be going on for them, and it will be easier to figure out why they might be fussing or crying. When your baby is fussy while trying to breastfeed, there are some things you can look for. Try to notice if baby fusses when the flow of milk changes. Some babies cough, splutter, and fuss if the milk letdown is fast and the flow of milk is difficult to control. Try a more reclined position with baby on top of mom so that gravity will help baby control a fast letdown of milk. Is the baby fussy when her drinking slows down? Try changing positions, switching breasts, and using breast compressions. Breast compressions are shown in the video on hand expression in Module 3. Sometimes the baby will suck for a while before the milk lets down, and baby gets frustrated. It can help to do some hand expression before putting baby to the breast so that there are some drops to start the feeding with. This can happen more often if baby is used to bottle feeding when the milk is there with the first suck. Most babies will start to fuss or cry more starting around 2 to 3 weeks. The crying will begin to decrease around 3 to 4 months. This is often referred to as the period of purple crying. You will find more information on this on the link to purple crying under the resources for this module. Check out the page on crying in Baby's Best Chance for good information on different soothing tips. Purple crying is normal, and some babies cry up to 5 hours a day. It is important to know what to do if you get frustrated because you have tried everything you know to comfort your baby. If the crying becomes overwhelming, you can have someone else take care of your baby if possible to give you a break, or put baby down on a safe surface and walk away. Never shake a baby. Because of their large head compared to their body and their weak neck muscles, just one shake can cause permanent brain damage. Remember, you can never spoil your newborn baby by responding and holding to comfort them. Doing these will actually build their sense of security and help promote healthy development. If you continue to have concerns about your baby fussing and crying, talk to your doctor, midwife, or nurse. Mild jaundice is common in newborns and happens when there is a buildup of bilirubin in the baby's blood. The bilirubin leaves the body through the baby's urine and stool or poop. Jaundice appears as a yellowing of the skin of the face and chest and the whites of the eyes during the first week and lasts a few days. In most cases, it is not serious and will go away with extra feeding. The best treatment for mild jaundice is to breastfeed often. More severe jaundice, if not treated, can lead to long-lasting problems. See your doctor for jaundice the same day if your newborn is not feeding well or appears more jaundice or dehydrated. The early signs that your baby may have more than mild jaundice are doesn't feed well or often, very sleepy and doesn't wake for feeds regularly or falls asleep during a feeding. The yellow color is more noticeable or progressing down the body, over chest, tummy, arms, and legs. Doesn't have the expected number of pees and poops per day. You can check out the expected numbers in Module 6 or in Baby's Best Chance. What can you do? If you are unsure or worried about any of these signs or symptoms of jaundice, talk to your doctor or midwife to find out if your baby needs any treatment. Check out the HealthLink BC for information. You'll find the link in the resources section for this module. Your baby may need treatment in hospital if there is more than mild jaundice. If your baby is at home and has mild jaundice, you have an important role to play. The best thing you can do is to ensure that your baby feeds well a minimum of 8 or even 12 or more times in 24 hours. Check baby skin 2 times per day to make sure that the color is returning to normal. Call your doctor and take baby for a check if unsure about how your baby is doing, and especially if the yellow color gets brighter after your baby is 3 days old. It can be very disheartening and stressful when baby doesn't latch, especially if they have previously. Some babies will refuse the breast for various reasons, and it often depends on what has happened with feeds previously. It is very different to feed from a bottle than a breast because milk will flow out of a bottle easily and immediately, even if a baby is not actively sucking. Feeding from a breast is a more active process than bottle feeding, and babies who have been given bottles will sometimes expect the less active effort of feeding. If you think this is what is going on, try massaging your breast before latching baby and put warm face towels over your breasts to help the milk start to flow. You can also try breast compressions while baby is sucking to increase the amount of milk baby gets with each suck, which may be more like the flow baby is used to from a bottle. In a similar way, a baby can get used to a shallower suck on a soother or pacifier, and may try this kind of suck on the breast and be frustrated when milk does not flow easily. We recommend to wait to introduce bottles or soothers until breastfeeding is going well, which takes on average 6 to 8 weeks. If you need to give your baby additional milk away from the breast, consider giving it in a cup. Cup feeding doesn't interfere with breastfeeding like bottle feeding does. There is a video on cup feeding in Module 3. A baby that will not latch may have had a negative experience with being pushed onto the breast, suctioned at birth, or some other unwelcome item being put in baby's mouth in the past. Some birth procedures, such as the use of instruments, can cause soreness or bruising on the head or another part of baby's body, and baby may be protecting the sore area by not latching. If you think that this is what is going on, try different positions that your baby might be more comfortable with. If favoring a position persists, take your baby to the doctor for a checkup. Another reason could be from thrush, which is a fungal infection in baby's mouth and mother's nipples. If you notice white patches on baby's gums or the inside of the mouth that do not easily wipe off, see your doctor or midwife. If it is determined that it is thrush, you will get medication for both of you because treating just one allows the infection to be passed back and forth from mom to baby. For more information on thrush, go online to Baby's Best Chance, where there is a more complete list of visible and not visible signs and symptoms of thrush. In general, some tips you can try with a baby that refused the breast are to go skin to skin with your baby to help trigger feeding reflexes. You can also express a drop of milk onto your nipples and offer it, or breastfeed when your baby is sleepy. You can also try to offer the breast after giving baby a small amount of expressed breast milk so that baby is calmer when you try. Avoiding bottle feeding can also help babies transition back to the breast. If you need to give extra milk, check out Module 3 for more information. If your baby is not wanting to latch, it is best to avoid the continuation of bottles or soothers. Because the way a baby drinks from a bottle is very different from the normal action of breastfeeding, it can be difficult to get a baby back to breastfeed once they have been given bottles. If you do choose to give extra milk by bottle, use the responsive bottle feeding technique, which may help your baby to return to the breast afterwards. If baby won't latch for whatever reason, we need to still feed the baby. There is research suggesting that when feeding babies away from the breast, using cup feeding is the least disruptive method to breastfeeding success. During the time that your baby is not latching for any reason, you need to protect your milk supply, and you can do this by hand expressing or pumping every 2 to 3 hours, just as often as you would be feeding your baby directly. Save this precious milk if you are not giving it to your baby right away. You can refrigerate your milk, and Module 3 has more about the details of how to keep expressed milk safe. When you have a plentiful supply, your baby will have an easier time transitioning to the breast. Sometimes practice, time, and patience is all that is needed for baby. Some babies go through a nursing strike where they refuse the breast even if they have never been given a bottle or dummy. Have confidence, these are often short-lived. Offer the breast when babe is calm and relaxed in a quiet and peaceful environment. You can try taking your baby in the bath with you. Nursing strikes can happen when babies are teething. Another technique you can try if you think baby is refusing because of bottles is to use a nipple shield which you can buy from pharmacies. Express some milk into it so baby can smell and taste the milk and breastfeed this way. Nipple shields are more like bottle nipples in texture and may help your baby transition back to the breast in these cases. Once they are feeding through the shield a few minutes, you can slip the shield out and see if baby is happy to keep nursing. You can also try limiting visitors and being skin to skin with your baby for a minimum 24, but better yet 48 hours continuously. Having your baby be in contact with you and smell your breast milk and have access to the breast can be a powerful motivator and way to start direct breastfeeding again. Try different positions like the cross cradle or football hold. This can be helpful during nursing strikes. Lastly, you can try a tube at the breast where you latch baby, then provide your expressed milk via a tube. Be sure to watch the videos on this and the resources if you want to know more about this. Ideal weight gain for healthy full-term infants is about 20 to 30 grams or 2/3 to 1 ounce per day in the first few months. It is always important to consider a number of different factors when looking at infant weight gain. For example, is baby full term? What is baby's birth weight? Medical conditions. Are the parents of small or large body type? Does the birth parent have any medical conditions? For example, we know that low thyroid levels can have an impact on milk supply. Some infant conditions can affect weight gain, such as sickness, allergies, gastric reflux, and even thrush, a fungal infection in the mouth. Was the birth natural or by C-section? Women who give birth vaginally often have their milk supply come in sooner. If you give birth by C-section, expect to have your milk come in fully a little more delayed, and keep putting baby to the breast based on feeding cues to encourage your milk to come in. Is baby feeding well? How are the pees and poos? Are they on track with what is expected for this age? Do you have an abundant milk supply and a fast letdown? Sometimes women with a lot of milk notice their babies don't grow as fast if baby is getting mostly the sugar-rich milk at the beginning of the feed and not the high-fat milk from each breast. If they fill up on the abundant supply but never get the hind milk, the milk that is high in fats, babies may have lots of gas, cramps, bloating, and slower weight gain. If you think that this is what is going on, try reclined breastfeeding to slow the flow and have baby empty one side more fully by staying on that side longer to get the higher fat milk. Is baby happy and content after feeds? Do you see the fullness signs after feeds described in Module 5? Are you hearing the swallowing sounds from about day 4 onward? There can be many reasons a baby has slower weight gain. If you are worried about your baby's growth, talk with your doctor, midwife, or public health nurse about your concerns. A tongue tie can be a challenge in breastfeeding. What is it? A tongue tie is when the connection between the tongue and the inside of the mouth is too close. Sometimes this tissue grows and stretches and the tie resolves. In other cases, it can affect the latch or the seal that baby can make around the breast and affect the feedings. It can also cause pain for the breastfeeding parent that does not improve with changes in positioning or adjustments to the latch. Your baby's tongue may not be able to stick out past their gum line or lips, or be able to stretch under the nipple while feeding. What can you do? You may find some comfort by trying different positions for breastfeeding and finding what works best for you. You can also work at a deep latch and wait for baby to open really wide before attaching. If the tongue tie impacts feeding, over time this can affect baby's growth and have a negative impact on your milk supply. For this reason, it is important that you get help early if you think that your baby has a tongue tie that is affecting breastfeeding. Talk to your doctor or midwife if you are concerned and see what options might be best for your particular situation. Spitting up. What is it and what causes it? Spit-ups can often worry new parents, but it is common in nearly all newborns as they don't have the same abdominal control that older children and adults do. Spit-ups are basically a small amount of liquid trapped under an air bubble, which then comes up when the air bubble rises and escapes. Spit-ups are normal, don't bother your baby, and often go away as babies grow. They are different from vomiting. Vomiting is more forceful and in greater amount and is upsetting to baby. What can you do? You can help by burping your baby often during feeds, between breaths, and after feeds. Another helpful option is to keep baby upright for about 15 minutes after a feed. This is often what healthcare providers advise for babies that have heartburn or acid reflux, so that the milk can move down and stay away from the esophagus or swallowing tube after feeds. If your baby is comfortable between feeds and is growing well, you can feel confident that what you are noticing are spit-ups and not affecting your baby's health. Remember too that spit-up you see is mixed with saliva and gastric juices, so is not as much milk and therefore calories lost as what it looks like. When you need help, if you are noticing that baby has forceful vomiting with larger amounts that looks more like the whole feed, baby's weight gain is slower than normal, and baby is in discomfort, be sure to talk to your healthcare provider. We will now look at some of the issues that you, as the breastfeeding parent, might come across. We start with looking at sore nipples because it is so common and an important issue to address. Sore nipples can be very painful, a great source of frustration, and a challenge as babies need to be fed every few hours, leaving little time to heal in between. One shallow latch can be a source of pain for days, so it is so important to get the help you need right away. A deep latch is when the nipple is far back in baby's mouth and is not being compressed by the hard palate and jaw. With a deep latch, the nipple shouldn't hurt because it is at the soft palate way back in baby's mouth. A good latch is very important. You may want to look at Module 6 again. If the latch is painful, adjust it. Break the seal by placing your pinky finger in the corner of baby's mouth and releasing the suction. Then relatch, holding baby close, tummy to tummy, nose to nipple, and swiping your nipple over baby's lips in a downward motion. When your baby's mouth is as wide open as it would be as if biting into a hamburger, bring baby in close to the breast quickly. Keep working on getting a deeper latch so it is comfortable for you. When baby comes off the breast, look at your nipple. If it looks pinched, flattened, or misshaped, chances are you're dealing with a shallow latch that can be corrected. Try different breastfeeding positions, as some might work better for you and baby than others. If your nipples are really sore, even with an improved latch, they may remain sore until they are healed. Breastfeed on the side that is the least sore first, as baby's sucking will be strongest at the beginning of a feed. Good nipple care is essential. Expressing a drop of your own milk and letting it dry on your nipple can help speed healing because of the many immune cells and beneficial properties found in your breast milk. Avoid harsh soaps and rubbing your nipples with towels, but rather pat or air dry after showering. If your nipple is so sore that you are unable to breastfeed, consider resting the one side for a few feeds and expressing that breast for baby each time you would breastfeed. This will protect your milk supply until baby is ready to feed at the breast. You can give baby this expressed milk fresh in a cup and let baby sip or lap it up. Remember, the key to sore nipples is prevention, and the best prevention is a deep latch that is comfortable for you. Get help promptly if you need support with the latch instead of just bearing through. You will likely make enough milk for your baby if you follow a few key strategies to help your body know how much baby needs. Your body generally makes as much milk as is removed, and this is partly why giving your baby anything other than your own breast milk can have an impact on your milk supply. If you're concerned about your milk supply, try the following strategies. Be skin to skin with your baby as much as you can, with baby just in a diaper and your bare chest. You can drape a light blanket over both of you up to baby's shoulders. Breastfeed baby skin to skin as well, because babies often feed best when they are not bundled or clothed, but just warmed by your body. Offer feeds based on your baby's early cues. Breastfeed often and at least 8 times in 24 hours, day and night. Night feeds are very important because that is when your brain is most sensitive to the hormones of milk production. Aim for 2 to 3 feeds per night as a good rule of thumb. Make sure baby has a deep latch that is not just nipple feeding, as that will impact your milk supply with baby removing less milk than with a deep latch. In addition, listen and watch for active sucking and swallowing versus non-nutritive sucking, which is more for comfort than for nutrition. If baby is not actively feeding, doing breast compressions, the gentle pressure on your breast for 10 or so seconds per area, can remind baby that there is milk to be had with a little more effort. Offer both breasts with each feed so baby gets as much milk as possible. As baby gets sleepy or tired and slows down, you can help with breast compressions which reduce your infant's workload. When you apply pressure to your breast during a feed, more milk is removed with each suck. Hand expressing or pumping after feeds helps your body make more milk and is a good way to increase your milk supply. Be sure to save and store your milk safely and have this available for your baby at a later time. There are herbal remedies that are sold for increasing milk supply, but studies have not proven that these are safe or that they work. There is a prescription medication called domperidone that has been shown in small studies to increase milk production. Talk to your doctor or midwife about this option if you have tried everything else and feel that this might be right for you. For more on domperidone, read the pamphlet Increasing Milk Supply from our Patient Education Catalog, linked under the Resources section. Inverted nipples are common and look like the image on the top right. If you have flat or inverted nipples that don't come out with stimulation, you may be wondering if you can breastfeed successfully. The answer is yes, you can. You can prepare to breastfeed before latching baby by gently rolling your nipple with your fingers, extending it manually. You can also use other types of nipple stimulation, such as using a hand or electric pump on low suction for a few minutes before latching baby. This may help draw out your nipple so that your baby can grasp it. Some women find using a cold cloth or ice cube wrapped in cloth useful to erect their nipples, but applying cold to the nipple can interfere with your letdown reflex, so be careful when using cold. You can also try reverse pressure softening, where you apply pressure with your fingers around your areola, the darker skin around the nipple, and push in gently towards your chest wall. This can help your nipple protrude, and your baby might find it easier to latch on. You can also try a nipple shield, as shown in the picture. Nipple shields are thin silicone devices that you can lay over top your nipple and allow the milk to flow through with baby suction. Nipple shields can be helpful in this case, giving baby something to grasp and latch on to. When using a nipple shield, it is important to make sure you get the right fit so that your skin stays healthy, and get support from a public health nurse, your doctor, or a midwife on how best to use the shield. Be sure to read more on this topic by downloading our Using a Nipple Shield patient resource. Some women are more prone to blocked ducts, but chances are if you breastfeed long enough, you might experience this. It is normal to have some firm areas in your breasts. The key is to take action quickly, as left untreated, these can escalate very rapidly into a much bigger issue. When you feel a firm area, this is a milk globule or duct that has some immune cells and milk stuck in it. It is very good for baby to get this, and bad for mom to keep it. Use a warm compress before feeding baby. While you are breastfeeding, expressing, or pumping, massage the firm area from behind outward toward the nipple. Keep massaging the firm area until you feel it release. It is also good to massage the lump before you breastfeed and between feeds. Women who are prone to blocked ducts find it helpful to feed their babies often and express their milk if away from baby for a longer stretch. Letting the milk stay in your breast longer can cause firm areas and plugged ducts. If your family or support person is feeding your expressed breast milk regularly, it becomes even more important to remove your milk frequently. Usually, a good rule is to express each time baby is being fed so your milk production can more closely match baby's needs. Engorgement tends to be painful, but there are some things you can do for this. Engorgement is when your breasts become so full that they are hard, sore, heavy, and often your baby won't latch as easily because your breasts are so hard and swollen. Much like you wouldn't be able to bite into a big hard balloon, your baby is unable to get a good latch when your breasts are engorged. Engorgement is preventable. In fact, prevention is key. As your milk comes in and your breasts get heavier and fuller, it is vital to keep moving the milk and not let it stay in your breasts for long periods. Latching and feeding your baby with a good attachment is the best way to move milk. Feed from the engorged breast first to remove as much milk as possible. If you are not able to feed baby directly, hand expressing and collecting the milk is another way, or use a pump instead. It is important to pump just for comfort so that baby can latch on and feed. Pumping a lot can make the situation worse, as it can increase your milk production even more. Whatever method you choose, the key is removing the milk instead of letting it build up. If you are worried that you might be getting engorged, gently massage your breast to soften your nipples enough so that baby is able to latch. Do this before each feed until you resolve the engorgement. You can also try reverse pressure softening, where you apply pressure to your nipples toward your chest wall for about 50 seconds before latching baby. You can also take nonsteroidal anti-inflammatories like ibuprofen to help reduce the inflammation and pain in your breasts. Cool cloths are helpful to reduce the swelling and discomfort after and in between feeds, and warm cloths before a feeding can help make the milk flow easier during a feed. Engorgement can be serious and may have a negative impact on your milk supply, so fast treatment is key to protecting your breastfeeding. If you're concerned, call 811 or your local public health unit for support. Mastitis can occur in the early days, but often it's later when baby is older and is not feeding as frequently. This is the beginning of an infection in the breast. It often starts as plugged ducts, a painful lump in the breast, but quickly progresses to your whole body feeling like you have the flu. Achy joints, possible fever, tired. You may or may not have a noticeable red area on your breast, usually on just one breast. Possible causes are going for many hours without feeding. For example, if your baby is napping a long time or starting solids at around 6 months, and your breasts are not emptying well, or plugged ducts and lumps have not gotten better. It is important to know that continued breastfeeding is advised and milk from the affected breast is safe for your baby. Key things to do are to rest, increase drinking your fluids, and move the milk. Massage out lumps right away while breastfeeding. Start on the sore side first. Offer breasts for more frequent feedings, pointing baby's nose or chin to the sore area when latching. Use warm compresses before feeds to help the milk flow. Offer breasts for more frequent feeds and start on the sore side first. You can also lay in a warm bath to help the milk flow, or put cool cloths on your breasts after feeds to help with the swelling and discomfort. Anti-inflammatories can help with the discomfort, but if you are not getting better within a day, see your doctor or midwife, as you may need antibiotics. Some women have had the unfortunate experience of being asked to stop breastfeeding, cover up, move somewhere else, or go to a bathroom while feeding their child in a public place. It is helpful to know that the BC Human Rights Code explicitly protects women and children while breastfeeding in any public area. For more information on the topics we have covered, be sure to search the web for Fraser Health Patient Education Catalog and then search by brochure name or topic of interest. We have also included many helpful links on these topics in the resources section of this module, so have a look at those good sources of information as well. If you have questions, be sure to talk to your doctor, midwife, nurse practitioner, call 811 24 hours, 7 days a week, or talk to your public health nurse for support. There is a lot of additional information on the topics covered in this module. If you want to learn more, be sure to check out these helpful resources that you will find when you return to the web page for this module. Thank you for joining with us on Module 8.